We all want to treat our patients as well as possible. And the surgical techniques allow us all this. But at the same time, there are situations where complications may occur. This is one patient who had this kind of cataract, and this is the fundus photo. This is the point where I have skipped up to the point where we are doing nuclear disassembly and emulsification of the nucleus. And this is a pretty simple kind of cataract, which we can see has a nucleus of grade 2 and 3. And we are simply proceeding ahead with horizontal chop, which is again not a challenging situation. And in this situation, I prefer to collapse the pieces out of the bag so that the bag safety is maintained. And once half of the nucleus is removed, we proceed for removing the rest of it. And this portion is being run at 1.5 times the normal speed, just so that we can reach to the point of interest as soon as possible. This surgery is being done under topical anesthesia, and we'll see what happens next. So this is some amount of cortical matter which is remaining, and we usually remove this using irrigation aspiration cannula, and that is being done here. So subincisional area is typically vulnerable for problems, and we'll see what happens. So here we have a little collapse of the chamber and then the posterior capsule rupture. You'll see this in slow motion. At a point, the cannula was withdrawn too much, and at that moment, the irrigation ports came out, and there was a collapse of the chamber. The aspiration was on, so the PC was caught, and there was a PC rent. Now, this is a situation we want to avoid. So, the first thing to do is do a reflux, move away from the area, stop your aspiration, and then replenish the anterior chamber with using viscoelastic gel and deepen it. And once this is done, it will let the vitreous go back to its site, and then you can reassess the situation. At this moment, because the rest of the cortex was gone, I decided to implant the PCIOL, and we can see it is a hydrophilic multifocal IOL, which has forgiving haptics, which I call because these haptics are more resilient to any damage and they are centered better. So because we can have access to the bag, so the IOL is gone into the bag, and then you simply let the optic scoop up the remaining cortical matter so that it is lying above the IOL. And now we will remove this remaining cortex, which may be mixed with vitreous. So you start aspirating at a point where the viscoelastic is there and it is away from the PC rent area. So this will avoid engaging the vitreous. And then you very gradually, in a calculated manner, move closer to the area where you have the cortex. And we can see we have engaged the vitreous, which is causing the pushing of the IOL towards the nasal side. And this is a point where we have refluxed, and then again trying to deposit the IOL to the center. There is a strand of vitreous which is floating in the anterior chamber, and we'll just see if we can sweep it away so that it is away from our aspiration port. So once we are sure that we have removed the vitreous from the wound, we'll place in a large air bubble, and this will help in multiple ways. It will keep the anterior chamber formed. It will also keep the IOL centered and also keep the vitreous pushed away. So after doing all this, we can see the next day picture shows an air bubble, the cornea clear, which indicates that intraocular pressure is normal, and also the PCIOL is well centered. The patient's vision at this moment was 6 by 18 and 6 by 12 BCVA. Thank you.